Welcome. My name is Anastasia Pantelias. I'm from Registered Development, and I'll be presenting on the results of our Health Campaign Effectiveness Project on behalf of all the partners at Bridges, WHO, Wipro, Kirby Institute, and the NTD program at the Ministry of Health in Vanuatu. Our project explored the ability to link campaigns in the primary healthcare system by evaluating the feasibility of integrating a mass drug administration campaign for NTDs with skin exams and referrals to PHC clinics, as well as collecting samples for active surveillance. In this presentation, I'll start with some introduction and background on the project, cover study objectives and methods, review some of the most interesting results, and then discuss what we can learn from this study, including promising practices, lessons learned, and implications for policy and future research. This project was nested within a larger implementation project managed by the same set of partners called the Pacific Integrated NTD Elimination Project, or the PINE Project. The PINE Project is a 3-year project in Vanuatu, which seeks to roll out integrated MDA in 3 provinces targeting yaws, scabies, and soil-transmitted helminths. As part of this project, the team was interested in testing the ability to include skin exams and referrals during the MDA, as well as to collect dried blood spots and stool samples in a subset of villages for active surveillance. The dried blood spots would be used to test for a variety of disease targets, including NTDs, vaccine-preventable diseases, enteric diseases, malaria, and flaviviruses. The final list of targets was agreed upon with the relevant divisions within the Ministry of Health. This helped support the implementation. This project was funded by the Health Campaign Effectiveness Coalition at the Task Force for Global Health, and it helped support the implementation of the integrated MDA campaign in the very first province to roll this out. And it also supported the subsequent feasibility evaluation, which is now informing the next campaigns in the other 2 provinces. Vanuatu is a small Pacific island nation made up of 13 principal islands and many more smaller islands. It was one of the first countries to eliminate lymphatic filariasis, and it has also submitted their dossier to the WHO to validate the elimination of trachoma as a public health problem. Although the Ministry of Health is small, it is highly committed to reaching their NTD goals, which includes elimination of yaws and leprosy and control of scabies and STH. Our project site was Tefea province, which is circled on the map in red. It consists of 5 islands and it has a population of about 37,000 people. We had 2 primary objectives for this project. First, to test the feasibility of creating a referral pathway between community-based MDA campaigns and the PHC system by including skin screening and exams during the campaigns. The second was to test the feasibility of leveraging the MDA platform to conduct active surveillance activities in a subset of survey villages. This included collecting dry blood spots for multiplex serosurveillance to inform country-level decision-making about health priorities, and stool samples for testing for STH. On this slide, we have a somewhat complicated schematic of the protocol for this study. Most villages in Tefea received MDA only, as shown on the left side of the slide. The team set up in a central location in the village, and the first point of contact with this was the registration table, where community members were recorded in the registration book. A team member was assigned to ask a set of screening questions to screen for yaws, leprosy, and any other severe skin disease. This screening was supported by job aids with photos of yaws and leprosy lesions, but the severe skin disease was not well defined. Community members self-reporting with suspected yaws or leprosy or a severe lesion was then referred to the skin exam table staffed by a nurse who conducted a full skin exam. Any suspected yaws cases were given a DPP test, which is a rapid lateral flow test for yaws, and the lesion was also swabbed for later PCR analysis if necessary. All DPP positive cases received a referral form to follow up at the local health clinic 4 to 8 weeks later to evaluate whether the lesion has resolved after treatment. They received azithromycin during the MDA, or if additional care was needed, and to look for a potential resistance to azithromycin. The nurse also referred any other skin lesion they determined needed additional care. All referred cases were recorded in the referral booklet, which was then delivered to the local health facility. If patients did not report to the health clinic, health workers were instructed to follow up directly in the communities. All community members then received MDA consisting of ivermectin and albendazole for scabies and STH. Because there was a shortage of supply of azithromycin due to COVID-related supply chain issues, only villages with suspected Yaws cases received azithromycin in the MDA. On the right side of this slide is the protocol for the subset of survey villages. MDA took place in 257 villages, with 17 of those being survey villages. The goal was to recruit 100 individuals in each village to participate in the survey for a total of 1,700 people. The protocol was generally the same as what I just described. However, for all individuals recruited into the survey, everyone received a full skin exam by a nurse. In addition, teams aimed to collect dried blood spots in 20% of recruited individuals and stool samples in 50% of recruited individuals. Otherwise, all aspects were the same and all community members received MDA. About 6 months after the MDA was completed, we conducted a survey to assess from the perspectives of the MDA teams implementing the MDA, supervisors, health workers, nurses, and volunteers, basically everyone who is involved in the teams doing the MDA, the feasibility and attitudes towards the integrated campaign. The survey was created in Bislama, which is the local language, and distributed through group communication channels, which are very active with the MDA teams. The Ministry of Health trained provincial health officers on how to administer the survey and provided tablets to the centers such that team members that did not have access to technology or with low computer literacy could come to the center and access the survey that way. There were, of course, many limitations in this study, many of which were driven by the COVID situation in Vanuatu. Vanuatu, unfortunately, suffered from its very, very first COVID outbreak in March of 2022, right after the MDA was completed, but before the scheduled follow-up. As all health personnel were reallocated to the COVID response and national lockdowns took effect across the country, health workers were not able to conduct follow-up in the communities during the time of our study. In addition, our plan for the feasibility study originally included interviews and focus groups. However, we were not able to do this and therefore needed to rely just on the online survey. Okay, so now moving on to some of our results. Overall, in a population of about 37,000 people, the MDA campaign reached just under 27,000, or about 73% of the eligible population. I'll talk a little bit about this in a bit, but teams found some areas with a high level of hesitancy that seemed to be tied directly to COVID vaccine hesitancy and refusals, as a vaccine campaign had just occurred the month prior in the province, and like here where I am in the United States, vaccination had become politicized. A few villages refused to let teams in at all due to fear and concerns about the COVID vaccine affecting our final coverage numbers. Everyone who participated in the MDA also participated in the skin screening. Over 7,000 people self-reported with a severe skin disease and were therefore examined by a nurse. Of those, 342 people received referrals to the PHC clinic for follow-up. In addition, 164 people were referred to the nurses' table with suspected Yaws, but only 12 were confirmed with a positive DPP test. While 342 referrals do not seem like a large number, for a country like Vanuatu with a small health system and no skin specialists in the country, this was actually quite high, much higher than we expected. And unfortunately, it did overwhelm the health system in Tefea province, with many referred cases not being able to be seen when they showed up at the health center. In analyzing the referral booklet, we found most referred cases were cases of scabies, which did not necessarily need to be referred as they were not severe and the community was receiving ivermectin during the MDA, which would treat those cases of active scabies. This result led us to rethink whether asking community members to self-report a severe skin disease with no specificity about what that meant, was leading to this over-referral. On the right side of this slide are some results around the hesitancy teams experience in the field. The takeaway here is that over 3/4 of the teams reported experiencing moderate, high, or very high levels of MDA hesitancy. In parallel, over half reported some level of hesitancy expressed by communities about the COVID vaccine. Remember, many of the health workers that participated in the MDA campaign also had participated in the COVID vaccine campaign the month prior. Team members reported confusion and associations between the COVID vaccine campaign and the MDA campaign, with one village refusing MDA entirely, thinking that the MDA teams had converted the vaccine to a pill, and that's why they had come back to distribute it. We also wanted to understand the team's attitude about providing skin exams in the community and integrating that activity with the MDA, which on both counts, as you can see in the 2 bars on the right, was entirely positive, with the teams agreeing that this was a valuable health service for the community. In addition, on the left side, teams felt that the job aids and the training that were provided were helpful and provided them with what they needed to carry out this activity. On this slide, we are digging more into the workflow of the skin exams and referral. What's interesting here is that the further down the workflow we get, looking at the bars from left to right, the more participants responded that they did not feel prepared. While 100% of the participants noted that they felt prepared to respond to community members self-reporting skin diseases, this percentage decreased when asked about preparedness to perform the skin examinations, and then went down even further when asked about preparedness to evaluate whether someone should be referred to the health system or not. From the comments, we learned that many nurses felt overwhelmed by the number of people self-reporting with skin lesions and requiring a skin exam. As a reminder, over 7,000 people were referred to the nurses' table for an exam. And secondly, the confusion around what exactly is a severe skin disease led to an over-referral of skin cases and likely contributed to feeling unprepared to properly evaluate whether someone needed to be referred. Moving on to the sample collection in the survey villages, what's interesting here is how much more challenging it was for teams to collect stool samples than dried blood spots. While teams managed to collect more than 80% of the dried blood spots they targeted, for stool, they only managed to collect about 20% of their target. They didn't report much resistance to collecting blood. However, due to cultural barriers, they reported significant hesitance around providing stool samples, especially from adults. So what did we learn from this experience? First, it is important to understand the capacity of the health system when trying to link campaigns to the PHC system. In our case, one of our challenges was the lack of skin specialists in the country. There was one pediatrician who had planned to travel to Tafea in order to see many of the scabies cases that were referred to the health system through the campaign. However, when he was not able to travel, many patients who showed up at the health center for follow-up were not able to see anyone. Understanding these types of issues, especially in a small country with limited resources, the absence of even just one health worker can have profound effects. So to try to mitigate this challenge for future campaigns, we worked with Wipro and the Ministry of Health to develop new skin disease training for health workers to try and build capacity at the local health centers using a peer-to-peer experiential case scenario-based approach. This training focused less on the traditional didactic information delivery and more on learning how to use the resources available, including their peers in their own and other health centers, to diagnose and treat skin diseases. The first training was rolled out in June, and it was very well received by the nurses who attended. Second, on deeper analysis of the referrals, we realized that many cases of moderate scabies received a referral when this was really not needed. Part of the reason is likely due to the vague severe skin disease category during the screening. For the next campaigns, we've eliminated that severe skin disease category and are focusing on finding cases of yaws and leprosy. Of course, if teams see anyone who requires additional care, whether it's due to a skin lesion or another critical condition, they should be advised to seek care. However, these should be rare and they are not recorded. Lastly, we did find an interesting spillover effect of hesitancy and refusals of the COVID vaccine. With the MDA campaign following closely on the heels of that COVID vaccine rollout, communities were sensitized, whether positively or negatively, on community-based health campaigns. In addition, we found that, much like here in the United States again, a lot of misinformation circulated on social media, which was not a communication channel that we used during the awareness training for the MDA. For the upcoming campaigns, we have developed a social media strategy to try and combat this. So we did see a few promising practices coming out of this work, including first, if you're going to try and create a link between campaigns and the health system, you need to make sure the health system is prepared to respond. In our specific case, we recommend providing health workers and nurses with in-depth training on skin diseases prior to integrating skin exams into MDA campaigns to ensure not only that the skin exams and referrals are effective during the campaign, but that there is capacity at the health clinic to care for the referred patients. This training should incorporate participatory and peer-to-peer approaches, be grounded in the experience of the health workers themselves, which builds confidence and creates a valuable peer network, which is what we're currently seeing in Vanuatu. This approach also enables better dialogue between health workers in the program to get a better shared understanding of the context and the needs of the health centers. Lastly, programs can expand their ability to conduct active surveillance by including it during MDA campaigns, though the challenge of collecting stool samples will definitely still need to be addressed. This, of course, leads to several areas for more research. First, around understanding the capacity building needs on the PHC side of things for a link between campaigns and the PHC system to be very effective. Second, as mentioned before, more research is needed to understand how to increase the acceptability of providing stool samples in order to increase the effectiveness of active surveillance for STH. The early feedback from our pilot of this new skin disease training was highly positive, but this needs to be scaled up and the approach needs to be better validated. And finally, as more and more communities use social media and get oftentimes very suspect information on social media, research on effective strategies to combat misinformation and hesitancy around community-based health campaigns is needed. In summary, our project showed that integrating an MDA campaign with skin screening, exams, and referral is feasible, and from the perspective of the teams doing the work, highly acceptable and highly valuable for the communities they serve. However, to do this as effectively as possible, capacity gaps on the PHC side need to be understood and addressed so that the link is complete. And finally, understanding what other campaigns are happening at the same time and how attitudes about those campaigns may affect yours. And if the prevailing attitude is negative, having a strategy for how to address that can help avoid drops in coverage due to these more extrinsic factors to your campaign. Finally, I'd like to thank everyone involved in this study, from Bridges, the Western Pacific Regional Office of the WHO, the Vanuatu Ministry of Health, and Kirby Institute in Australia. I'd like to acknowledge our funders, including the Task Force for Global Health, who provided funding to support parts of the implementation of the campaign, as well as the feasibility survey and the pilot integrated skin disease training, and Takeda Pharmaceuticals Limited Global Corporate Social Responsibility Program, who funds the overall PINE project in which this project was nested. Thank you.